Good afternoon, everyone, and welcome. Today's lecture will focus on the Blue Ribbon Panel Recommendation F, Symptom Management Research, and specifically on an RFA titled Analyzing and Interpreting Clinician and Patient Adverse Event Data to Better Understand Tolerability. Next slide, please. So the recommendations are as follows. 1, to identify approaches to monitor and manage patient-reported symptoms and integrate the information to revise and update national guidelines for symptom control and support. Secondly, to improve symptom care for cancer patients and survivors, including survivorship in racial ethnic minorities and other underserved populations. To make PRO measurement technologies available to all patients. And this has become very critical in the age of COVID because we are relying more on telehealth. There's more avenues now and need for handheld reporting of PROs and symptoms. And lastly, develop systems for the routine monitoring and management of patient-reported symptoms across the cancer continuum and integrate these systems into overall care delivery. Next slide, please. So to focus on the last recommendation, which is to minimize cancer treatment's debilitating side effects, and to realize this, it's to look at and accelerate the development of guidelines for routine monitoring and management of patient-reported symptoms. So of this recommendation came the RFA. The overriding purposes are twofold. 1 is to stimulate the development of methods to better understand cancer treatment tolerability by analyzing clinical trial adverse event data and patient-reported data. And so an example is that we now have clinician-reported AE data as well as PRO data. We have developed the PRO CTCAE, or Common Terminology Criteria Adverse Event Reporting. Clinicians are reporting that data as well as patients. So how do we harmonize those, and how do we look at analyzing and integrating that data together? A second example is baseline symptoms. Have patients that come on to treatment already experience symptoms, and as they receive treatment, they will develop new symptoms and new adverse events. So how do you integrate and how do you analyze that data? The second purpose of the RFA is to create a consortia of funded investigators to share analytic approaches. Next slide, please. So here's the Tolerability Consortium that was formed. There are 4 funded research teams. Dr. Gantz, who will be moderating today, is one of the grantees. In addition is Dr. Mohile, who we'll hear from today, and her focus is on understanding treatment tolerability in older patients with cancer. Next slide, please. So I will turn it over to Dr. Gantz, and let me go ahead and say a few words and introduce her. Dr. Gantz is a medical oncologist, and she specializes in breast cancer and prevention. She is the director of cancer prevention and control research at UCLA, specifically at the Johnson Comprehensive Cancer Center there. She is also a faculty member at the School of Medicine as well as School of Public Health at UCLA. She has really been a pioneer and has paved the way for much of the research in health-related quality of life. In addition to this area of research, as well as her research in breast cancer and prevention, she also has a lot of research in the area of cancer survivorship, as well as late effects of cancer treatment. So thank you, and I'll turn things over now to Dr. Gantz.
Thank you so much, Diane. It's a pleasure for me to introduce my colleague, Dr. Supriya Mohile, who is the Philip and Marilyn Wareheim Professor of Medicine and Surgery at the University of Rochester. She is a board-certified geriatrician and oncologist, which is a rare combination, but very important. And good to know that she completed her internship and residency and fellowships in hematology and oncology and geriatrics at the University of Chicago Medical Center, where she also earned a master's degree in health outcomes research. In 2013, she was awarded a Patient-Centered Outcomes Research Institute Award and an NCI R01 to evaluate whether geriatric assessment can improve outcomes of older patients with cancer. Both studies have been completed and will be discussed today. The R01 GAP study provided data for her U01 application, where she is working closely with other investigators and the NCI to better understand treatment tolerability in older adults with cancer. And by the way, older adults are the majority of individuals who have cancer. Dr. Mohile is an expert in geriatric oncology with over 200 publications in the area, and she served on the editorial board of the Journal of Clinical Oncology and is editor-in-chief of the Journal of Geriatric Oncology. Welcome, Dr. Mohile.
Thank you so much. It's really an honor to be introduced by you, Dr. Gans. You've influenced my work in so many ways. And thank you also to Diane and the other organizers. I'm just going to share my screen here. The panel. So I will get started in the lecture because I really want to have time to discuss the content that's related. And Dr. Gans, you can see my slides, right? I always get a little nervous. Okay, great. So I'll start by really communicating the demographic imperative, as Dr. Gans has alluded to, that the proportion of patients with cancer who are older is the majority of patients with cancer. And we really have significant gaps in knowledge related to geriatric oncology that we need to remedy in order to provide best evidence for these patients that we see in the clinic. I'll discuss some results from our trials that show that geriatric assessment can really improve treatment tolerability, and then talk about work from the U01 Consortium that has helped us to expand our framework for tolerability. And I'll end by discussing efforts in the past and moving towards the future to try to improve the evidence base for older adults with cancer. So this was a study that showed that between 2010 and 2030, there will be an increase in incidence in patients age 65 and over of cancer by 67%. And this is compared to 11% increase in incidence in patients younger than the age of 65. And it's because age is such a significant risk factor for cancer. I just want to comment that the proportion of patients that's growing fastest than any other in our population are those age 75 and over. And this population is growing 4 times as fast as any other group. Unfortunately, older adults are not included onto therapeutic clinical trials that establish the evidence for that provide us with evidence about safety and efficacy of treatments that we use in the clinic. This is work done by Dr. Harpreet Singh, who's a strong advocate of geriatric oncology within the FDA. And she presented data of the 10-year perspective of FDA registration trials from 2005 to 2015. And while in the community, the majority of patients with cancer are older, as shown by this red bar graph, the percent that are enrolled onto FDA registration trials is much lower, especially for those age 75 and older. And this presents significant gaps in clinical care for older adults with cancer. In our geriatric oncology clinic at the Wilmot Cancer Institute, we evaluate older patients with cancer pretty commonly. And this is one of my patients who I really struggled to come up with a comprehensive and evidence-based plan for treatment for his rectal cancer. This is who he says is his caregiver. She didn't live with him. This is his daughter, who's a nurse. And the problem is that the majority of older adults with cancer, about 2/3 of them, have problems outside of cancer, beyond just comorbidity, but including functional issues like needing assistance with daily activities, cognitive impairment, social support limitations, polypharmacy, and frailty. And these patients are not included onto phase 3 trials or registration trials. In 2013, there was an Institute of Medicine report, IOM is now the National Academies, called Delivering High Quality Cancer Care, Charting a New Course for a System in Crisis. The editors are listed here, and Dr. Gantz being a key member of this team. The recommendations at that time was that there was a critical need for research in older adults with cancer, and some solutions were to incentivize to do this research and really use multidisciplinary teams to develop a better understanding of appropriate research design infrastructure for older specific trials, to recruit older adults onto studies, and better reporting of results. And this was summarized by Dr. Arthi Huria in a JAMA paper in 2013. And I just wanted to comment at the beginning about Dr. Arthi Huria, who is a leader in geriatric oncology and a mentor of mine, because her influence will be shown throughout this talk. She unfortunately passed away unexpectedly in 2018. And a lot of what we do in the geriatric oncology community is based on her legacy. So how can we improve care delivery? Well, geriatric assessment is derived from our geriatrics colleagues or developed by our geriatric colleagues as an approach to the evaluation of the older patient, which can help us identify areas of vulnerability that put older adults with cancer at highest risk for adverse outcomes or poor tolerability from treatment. The geriatric assessment evaluates these geriatric domains listed here: function, objective physical performance, comorbidity, cognition, nutrition, psychological status, social support. And we know by having conducted a robust ASCO guideline that was published in 2018 that evaluated over 60 high quality studies, that each of these domains is an independent predictor of morbidity and mortality in older patients with cancer. The summary of, the background in geriatric assessment is listed on this slide. So geriatric assessment can really help identify older patients that are at highest risk for toxicity from treatment and early mortality. And by doing so, it can guide decisions in care management. We conducted a study called the COACH trial that showed that geriatric assessment helps identify impairments and improved the content and the quality of conversations related to aging at the point of clinical oncology care. So oncologists that received a geriatric assessment talked more about the concerns that a patient had related to things like cognition and falls with higher quality and leading to more geriatrics-based interventions that could improve clinical outcomes. As an early career faculty member here at Wilmot Cancer Institute, I received funding from both Wilmot Cancer Institute and through NCI-R03 to really think through the development of a multi-component model of care intervention for older patients of cancer. And I conducted with my colleagues a Delphi consensus process with geriatric oncology experts throughout the country that use geriatric assessment in clinical oncology care. And I asked them who should get geriatric assessment. And they basically said, like the ASCO guidelines, every older adult age 70 and over should have some form of geriatric assessment. We asked about streamlining the geriatric assessment domains, and they felt that each domain being an independent predictor was too important and that we had to really assess each one. And so that's on the left column. However, which test you can use for evaluating the domain can be adapted for the patient population or the resource setting. And there's not really strong evidence in many settings of one test being better than the other. And so there are options here, although there are some standard ones that we use very commonly within a geriatric assessment. In addition, the experts were able to provide consensus on common process outcomes to be used if a patient were to have an impairment on a geriatric assessment test for the domain. So for example, if a patient had balance issues, we could do an objective test like the short physical performance battery, which is a validated test of balance, gait speed, and chair stands. And if they score poorly on that because of impairments, we could implement things like physical therapy, occupational therapy, exercise, and home safety evaluation to support the patient during cancer treatment. And so this background lended itself to a multi-component intervention. We were able to achieve R01 funding through the NCI to run a multi-site study to evaluate if providing a geriatric assessment summary with recommendations, so a geriatric assessment model of care intervention with oncologists, so in community oncology clinics without much geriatric expertise, could improve tolerability. And we measured tolerability using standard tolerability metrics in clinical trials, like CTCAE, common terminology criteria for adverse events that is clinician rated. So this is the most common way that we communicate tolerability. And we wanted to see if it reduced the proportion of grade 3 to 5 toxicity, which is pretty significant toxicity ranging from severe to life-threatening to fatal. We also looked at survival and treatment decisions. We were fortunate to be able to conduct this study within the University of Rochester Cancer Center NCI Community Oncology Research Program research base. We are a coordinating center for NCORP at the University of Rochester, one of two nationally that are housed in an institution, the other being in Wake Forest, and 5 additional NCORPs within the cooperative groups. Our NCORP is led by Dr. Gary Morrow, who I know is out there listening and has been a longtime mentor of mine, as well as Dr. Karen Muschin, who's a friend and a colleague and co-I on this study. We were able to enroll patients from community oncology clinics affiliated with our NCORP who received funding from the NCI to enroll patients onto cancer control and supportive care trials. Our study design was cluster randomized. So this is URCC 13059. We did not randomize at the patient level. We randomized at the practice level. The reason for that is we didn't want to bias results as a physician or patient learned about the interventions. The physician could use those interventions for the next patient they enrolled, whether or not the patient was enrolled as an intervention or usual care if it was a patient level randomization. So cluster randomized studies are better equipped to evaluate models of care interventions. Our intervention was low touch, one time. The physician received one geriatric assessment summary and the recommendations. In addition, we collected robust information about treatment decisions, chemotherapy, AEs, and the relationship between AEs and treatment decisions, using NCI CTCAE primarily because that's our clinical outcome. And I'll talk about PRO CTCAE a little bit later because we also incorporated this in our trial. So what was the intervention? I mentioned that it was low touch, one time. The staff in the clinic, mostly the research staff, but sometimes the clinical staff, were trained to do geriatric assessment. They entered the results into a web-based tool, and then a summary was printed out that was tailored for each patient. If a patient had an impairment in a domain, the summary was printed out for that impairment. And here's an example of the summary for a physical performance impairment that talked and educated the oncologist about falls and other geriatric syndromes that are important to older adults, as well as communicating the geriatric assessment results. In addition, the oncologist received two pieces of information for recommendations, one being a communication intervention recommendation list, where the oncologists were asked to really think about the risks and benefits of treatment in light of that impaired domain. Think about that impaired domain as an outcome. So someone with physical performance deficits, think about the impact of treatment on falls and address the impact of treatment on function and independence. The management recommendations were derived both from the expert consensus panel that I discussed earlier and from guidelines like from the American Geriatric Society guidelines, and utilized common geriatric management recommendations. The oncologists had complete control over what they did with this summary. They could throw it in the garbage, they could walk away from it, or they could actually do the communication and management recommendations and pick which ones they wanted to do. We also didn't prescribe cancer treatment. This was up to the oncologists. It was their patients. So we gave them the information and they were able to make decisions as they thought appropriate. The patients that were enrolled were 70 and older with a diagnosis of advanced solid tumor lymphoma. And they had to have at least one geriatric assessment domain impairment other than polypharmacy. The reason for this is we wanted to enroll patients that are routinely excluded from other cancer clinical trials and study the effects of palliative treatments for patients with incurable cancer that have generally have a narrow therapeutic index. All of the patients were starting a new chemotherapy regimen or another regimen with high risk of toxicity. This table shows the patient characteristics. The average age of the patients was 77, much higher than those patients that are enrolled onto therapeutic clinical trials, unless those trials are older patient specific. Fortunately, the majority of our patients were white, and we hope to do better with this in the future. The patients who were Black enrolled primarily onto the intervention arm, likely the way the practices were randomized, and we randomized 40 practices. The majority of patients were had either gastrointestinal or lung disease and were stage 4 and were receiving chemotherapy. And about 25% of the population had received prior chemotherapy, meaning the majority of patients were treatment naive enrolling onto our study. I'm continually surprised by this slide every time I show these results. We had 718 patients enrolled, and the patients were much frailer than I expected, even as a geriatric oncologist. Remember, these are patients receiving chemotherapy and other high-risk treatments. The median number of geriatric assessment domain impairments was 4.5. We in geriatric oncology think about 2 domain impairments really being correlated with frailty. So these are really frail older adults. Over 90% had physical performance domain impairments. Over 30% had cognitive impairments. And thinking through this, we know that we have almost no data of the safety and efficacy of cancer treatment in patients who have cognitive impairment. And yet these patients in the community are receiving treatment because we lack information on this data. After looking at the domain impairments, it's not surprising to know that there was a significant prevalence of adverse events very quickly after patients started treatment. Over 60% had a serious toxicity as rated by clinician-rated CTCAE within 3 months. 50% had dose modifications, many discontinued treatment, and over a quarter of patients passed away within 6 months. So again, this is a palliative. These treatments are palliative, not curative. We did find that the geriatric assessment intervention improved tolerability by lowering CTCAE or grade 3 to 5 CTCAE toxicity over 3 months with a risk ratio of 0.74. The prevalence of having any toxicity in the intervention arm was 50% compared to 71% in the usual care arm. And this played out more with non-hematologic toxicity, or those toxicities we think of as really influencing quality of life, like fatigue, neuropathy, GI complaints, rather than hematologic toxicity. So the conclusions from URCC 13059 was that a geriatric assessment intervention can really improve tolerability, but as evidenced by reduced clinician-rated grade 3 to 5 toxicity over 3 months. We found that the intervention did not lower survival at 6 months. And so the survival was equivalent between arms. This supported the use of geriatric assessment for older adults starting a new chemotherapy regimen. And there are other studies that were presented at ASCO 2020 that had similar results, especially one that was presented by Dr. Dan Lee in collaboration with Dr. William Dale, a study that was designed by Dr. Geriatric that showed similar results for patients with both curative intent and advanced cancer. But what is the mechanism? And so here's where the tolerability metrics can really help us. I'll pause by defining relative dose intensity. So relative dose intensity is the amount of drug administered per unit time expressed as a percentage of the planned dose or standard regimen. We evaluated relative dose intensity in comparison to standard dosing as defined by the clinical trials and NCCN. Clinical tolerability measures are wonderful, such as RDI can be great because it incorporates things like dose reductions and dose delays related to AEs. And there's been some work to show that reduced RDI is associated with worse outcomes in patients with curative intent approaches to therapy and generally in younger populations, but very little is known about RDI in older patients with advanced cancer. We evaluated treatment intensity by arm to see if this was a mechanism for the reduced AEs that we found. And we did find our hypothesis played out that the oncologists in the geriatric assessment arm or in the intervention arm were more apt to reduce the dose intensity at cycle 1 compared to those in the usual care arm. So they started at a lower dose, and sort of this philosophy we have in geriatrics of start low and go slow was followed by the oncologist in the intervention arm. This did lead to an overall slightly reduced relative dose intensity over the course of 3 months, but the gap was closed somewhat because in the usual care arm, patients experienced dose delays and dose modifications related to toxicity after the fact. Again, even though there was a lower relative dose intensity, survival was not compromised. And this tells us that the dosing and the approaches to treatment that we're learning from FDA registration trials and from cooperative group phase 3 trials may not be relevant to older patients who have other medical problems besides cancer. So the U01 option came up sort of as I was finishing up the URCC 13059, and it was one of those things where you see it and you see it a little late and you're working over the Christmas holidays to do it because it just needs to be done. And we were lucky to have a clinical trial that had CTCAE, PRO-CTCAE, and other patient-reported outcomes that were requested by the RFA that Diane mentioned earlier. So we were able to submit for this U01 and be part of this consortium. At the beginning of the U01 consortium, the consortium leaders and investigators really thought through the definition of tolerability. And we kind of went back to this Friends of Cancer Research definition, which I personally appreciate quite a bit. This was developed in collaboration with patient stakeholders and with the FDA. And I'll read it. The tolerability of a product is the degree to which symptomatic and non-symptomatic AEs associated with a product affect the ability or desire of the patient to adhere to the therapy. A complete understanding of tolerability should include direct measurement from the patient on how they are feeling and functioning while on treatment. So clinician-rated CTCAE does not do that. Patient-reported outcomes like the PRO-CTCAE does. And then also incorporating functional measures is important. Our context that we add value to the U01 consortium is that our treatment is from community-based oncologists with patients receiving what we think of as standard of care for their diagnoses, and that we have older patients who are more vulnerable and frail with advanced and incurable cancer. What is PRO-CTCAE? So PRO-CTCAE was developed early on by Dr. Sandy Mitchell and investigators like Dr. Ethan Bash and Dr. Amy Lou Dueck to be complementary to the clinician-rated CTCAE approach to managing AEs. And it was developed to evaluate symptomatic toxicity in cancer clinical trials, and these teams have already incorporated PRO-CTCAE into therapeutic trials. All the other 3 teams that work within the U01 consortium have done this. And there's a library of items. Each of the items has different attributes that I'll show on the next slide, where investigators can go on the website and choose items that they think are most appropriate for their trial. Before I move on to the PRO-CTCAE that we included, I want to give a shout out to Dr. Sandy Mitchell. So the way that we incorporated PRO-CTCAE is in 2013, I saw Dr. Sandy Mitchell give a talk about the development of the PRO-CTCAE at ASCO. And I went up to her sort of kind of end of my junior faculty and asked her if I could include this measure in my trial. And she was so gracious and helped me get a data use agreement with the NCI to be able to include one of the earlier versions of PRO-CTCAE in our trial. So we chose 27 of the items that we thought were most appropriate for older adults receiving chemotherapy. Each of the items, as I mentioned, has different attributes. So 8 of our items had frequency as an attribute, 24 had severity as an attribute, 16 had interference as an attribute. And much of our analyses thus far has focused on severity as an attribute because that's the attribute that's the most prevalent in our items. We collected the data at baseline, and I'll show you why baseline data collection, as Diane mentioned, is so important. And at 4 to 6 weeks, 3 months, and at 6 months. Our aims are listed here. One of our main goals was to look at trajectories of PRO CTCAE scores and clinician-rated AEs over time in the patients receiving treatment as related to underlying aging-related conditions. We also looked at the associations of PRO CTCAE with clinical outcomes like dose modifications, hospitalizations, and mortality, and with patient-reported outcomes that could help us really learn about the patient experience. And we did have the wherewithal at the beginning of the study, not knowing that this U01 opportunity would come up later, to include a lot of these metrics within the GAP trial that I discussed earlier. So here was our conceptual model that communicates our proposed operational model for tolerability, where both CTCAE, that's clinician rated, and PRO CTCAE add value in understanding tolerability. And what we wanted to do was look at the relationship between these with clinical tolerability metrics and patient-reported outcomes, including functional metrics that we measured with a geriatric assessment, and also patient experience metrics that we had included in the trial. I also want to thank my team before I move forward into the data, because this team, we never work as individuals in clinical research teams. And this work that I'm presenting today is not mine, it's the team's work. And I really want to thank Dr. Marie Flannery, Dr. Eva Cholikova, and Luc Pepone for leading these teams and being part of this consortium effort, as well as the other investigators and Ms. Beverly Kanan, our patient stakeholder, who has been quite involved and helpful in helping us look at the data. So I'll go through each of the aims briefly and kind of communicate what we've learned. Again, we've looked mainly at the severity attribute. This is baseline data from this older patient population with aging-related conditions. And remember, only about 25% of patients had chemotherapy prior to starting this study. Most were chemotherapy naive. And there was a high prevalence of symptomatic burden at baseline, with fatigue, pain, decreased appetite, and insomnia being very highly prevalent, and having pretty severe, having patients reported as reasonably severe, not very severe. The grade 4 was infrequent, but we had quite a few patients with both grade 2 and grade 3 at baseline. And so we're seeing a lot of baseline symptom burden. And as oncologists, we really hope that when we're giving palliative treatments, that it's improving symptom burden. But unfortunately, we did not see that as much with this patient population. The patients had baseline burden, maybe from prior treatment, but likely from their cancer. And the burden increased over 6 months on average for each of the items that I presented on the previous slide. And so very high prevalence of fatigue, for example, 95%. So we're seeing a really high symptomatic burden in older patients with cancer, with aging-related conditions. And how to tease the cancer burden out from treatment burden is important for future work. Like other investigators before us, we evaluated many of the items in terms of what the clinicians found, clinician-rated AEs, in relationship with what the patients were reporting. And this is work by Dr. Cholikova, who is our lead statistician at the URCC NCORP research base. She presented this at one of my favorite meetings, SIOG, which is the International Society of Geriatric Oncology, and showed that clinicians did not identify as much symptoms of neuropathy, which is this dark, sort of bright blue here, as much as what patients reported, which is this gray line. So big discrepancy for older adults in which patients are reporting for neuropathy compared to what clinicians are reporting. And then when we look at this right-sided bar graph here, what we can see is that what clinicians report are the most severe the cases with the most severe symptoms. So patients who are reporting very severe neuropathy on the PRO CTCAE. They're missing probably because it's not communicated, or patients may not think it's important, or it's not sort of delved into deeper, the mild and moderate numbness and tingling that patients experience. And so this shows how PRO-CTCAE can be, you know, an opportunity for early intervention before things get to be too severe. As part of the U01 Consortium, we're learning about data visualization. So I've showed some bar graphs that show averages. And I think that can fool us into thinking that patients stay in their same box as time goes on. But that's not really what happens with the patient experience. Individual patients have individual things happen with them and to them. And so this is a Sankey diagram that can actually show the flow of what happens to patients over time at different levels of symptomatic burden. And we use neuropathy here, numbness and tingling, to show what could happen. Each of the lines' thickness is the number of patients. And so for patients in the green who are none at baseline, some remained none all the way through, but some went to mild and some went to moderate and some went to dropout. They dropped out from this study. If we look at moderate, which is orange, there's fewer patients, the lines are narrower, but some get better, they go to none, some go to mild and some go to severe. So this really communicates better the individual level of patient experience and could serve as a communication tool with patients who are concerned about some specific toxicities. And I know Dr. Gantz with her team is working on Sankey diagrams that can be used at the point of communication to discuss AEs with patients, between patients and clinicians. Moving to AIM-1, we wanted to evaluate as a reminder to the audience the relationship between aging-related conditions and comorbidities with symptomatic burden, severity, as measured by PRO CTCAE. And we looked at individual geriatric assessment domains and individual comorbidities. So here at the top, we looked at patients who had impaired social support, impaired nutrition, and impaired function. And you can see that there's differential effects on symptomatic burden based on specific underlying aging-related conditions in this population having nutritional impairments and functional impairments leading to worse severity scores over time. And then with comorbidities, also specific comorbidities matter. Arthritis matters to older adults, and we can see that patient-reported symptomatic burden worsened over time for patients with arthritis and heart disease, but less so with those with liver and kidney disease. So we often are, trying to count things up or combine data, but we have to remember for patients in front of us, what they have individually can matter, and their health status characteristics matter. Our statistical team led by Dr. Chilakova used clustering to be able to identify groups of patients that may have differential risk. And in this slide, we're presenting hierarchical clustering that is showed by a heat map here, and each of these little lines is an individual patient. And you can see that there are patients that have very little symptomatic burden. This is in 1 and 2, sort of the green. And those patients that have higher symptomatic burden, 3 or 4. The patients that had higher symptomatic burden, this is the purple and the red line on the upper right-hand graph, had a higher prevalence of, higher likelihood of having worse function over time. And in this slide, we're showing function using instrumental activities of daily living, which is it's a key metric, patient-reported metric for older adults with cancer that measures ability or likelihood of a patient living independently in a community. Whereas those patients with lower symptomatic burden didn't have as much functional decline. In addition, the patients that clustered into the higher symptomatic burden groups by PRO CTCAE were more likely to drop out from our study than those that didn't. And so we're seeing that there are groups of patients based on risk of symptomatic burden at baseline that may have functional consequences as they move forward with treatment. Dr. Zhu, another NCORP statistician who we love working with at URCC NCORP research base, also looked at clustering using a different methodology, unsupervised machine learning. And he was able to identify 3 clusters of patients in a low severity group, moderate severity group, and high severity group. and showed that these clusters were also related to clinical outcomes like hospitalizations, death within 3 months, or dose modifications. And he presented this at ASCO Quality Care last year. So in addition to looking at individual items, these clusters could help us identify at-risk vulnerable patients. So as was mentioned earlier, the consortium is really a group of people, investigators working together with the NCI to learn. And it's been super fun working with these teams. And our team has really learned from the other teams. And I want to thank Dr. Lori Minasian and Sandy Mitchell for providing great leadership and being so engaged and helpful and kind of pushing us forward in the consortium. Here's what we've learned from each of the teams. So from the Drs. Bash and Dueck groups, we've learned how to operationalize PRO CTCAE and analyses in clinical trials. Here are some references. They're key leaders in sort of demonstrating both PRO CTCAE and CTCAE data in clinical trials to assess tolerability. We're learning about how to use advanced statistical methods to help us evaluate toxicities and AE data from Drs. Rogatko and Gantz. They developed the toxicity index, which was just published in JNCI. And I would say that this is a great paper to read because it shows how to analyze, it sort of streamlines and really considers the different attributes in composite way that we can evaluate toxicities and report the toxicities and incorporate the toxicities and analyses. And then from the Drs. Gray and Wagner groups, we're really learning about the patient experience. So this group has really focused a lot of their work and brought forward a lot of their work using the GP5 question, which is a question out of the FACT quality of life scales that discusses the bother of AEs to the patient, and showed that the GP5 is related to early discontinuation of treatment. So we've tried to learn from the other groups with our methods, and Dr. Chilikova presented this at ASCO Quality Care last year that showed that the geriatric assessment not only improved clinician-rated CTCAE, but also lowered patient-reported symptomatic burden. And we analyzed the results using the methods from Bash, Rogak, and Dueck, and the citations are here at the bottom. And we also looked at core symptoms being the core symptoms that are recommended by Reed, Mitchell, and Dueck. There's a high prevalence of patient-reported symptomatic burden, as I said, but we can reduce that with geriatric assessment, likely through improved decision-making for treatment. And then building on the Gray-Wagner team, we looked at our patient experience outcomes, decision regret, satisfaction with cancer therapy, and GP5. And we know that there are validated tools to assess decision regret and satisfaction with cancer therapy. We use something called CTSQ, the Cancer Therapy Satisfaction Scale, but these are these are not commonly incorporated into trials. And what we found is intuitive, but sort of played out with each of the measures, that those patients that experienced a toxicity or hospitalization or dropped out from the study had worse satisfaction with cancer therapy, worse decision regret, and overall were sort of unhappy that they began cancer therapy. So if we can identify these patients earlier, we would save sort of emotional distress and help them cope and help them do what's better for those individual patients. I don't want to have a talk where I don't talk about social determinants of health, which are so important to older adults with cancer. And all patients with cancer, really. So we did an analysis looking qualitatively at our data from one of our earlier trials that I presented earlier in the talk, looking at financial toxicity. We have to remember that things like financial toxicity are likely related to AEs. We found that some of our older patients were not picking up their supportive care meds because they're making choices about their finances and using them instead for things like gas or for their families. And so if we're not measuring financial toxicity and other metrics like this, we're losing some important information about AEs. I'll summarize with this slide. This is a slide that really incorporates a lot of the information that I presented today in this talk. This is developed by Dr. Flannery and will be published in a Journal of Clinical Oncology special issue for Journal of Clinical Oncology special issue for geriatric oncology that will come out around June, that's being edited by me, Dr. William Dale from City of Hope, and Dr. Paul Jacobson. And what it shows is across the continuum that all of these metrics really inform tolerability, not just clinician rated toxicity, which is what has sort of been standard for therapeutic clinical trials. That at the beginning of treatment for shared decision making, we really need to think about aging related conditions and social determinants of health. We really need to think carefully about what the goals of treatment are and what the likelihood of dose adjustments are. Should we do it at the beginning, or should we do it, should we allow it to happen later after a toxicity? Yes, we should still think about clinician rated CTCAE, but the patient reported CTCAE and other symptom burden measures may add a lot of value. And functional measures, especially those from geriatric assessment, are very important for this population, are endpoints that are highly valued by older adults with cancer. Global metrics can also be helpful, like decision regret and satisfaction, to learn whether or not a therapy is worth it for a particular population. I have a few slides about evidence. So there's been a lot of movement forward over the years to try to improve accrual of older adults to clinical trials and to get better evidence for this growing and important population. And this is a slide that was presented by Dr. Kleppen at the recent National Academies meeting that shows that from the original 2013 report that I communicated earlier, that there have been multiple efforts by FDA and ASCO and the National Academies and the NIH to try to come forth with recommendations. And the recommendations have been consistently very similar to the original IOM report. We have the Cancer and Aging Research Group, which is really an informal, I think it's informal, it's becoming more formal because we have infrastructure funding through the NIA and have developed cores to be a resource to investigators, research cores. But we still like to think of it as informal. It's really for anyone interested in cancer and aging. You can go to the website called mycarg.org and apply for membership. There's no cost. You'd be invited to our meetings. And we really try to communicate mentoring and mentor early career faculty and those that are interested in integrating aging and cancer and develop clinical trials for older adults. And I want to thank Diane St. Germain, who started off this talk today for an effort that she's doing with me, where she applied for funding to do a workshop to develop practical recommendations, building on all the efforts I've discussed for NIH trial, NIH funded trials, NCI funded trials, to really be able to improve accrual of older adults and to integrate geriatric assessment into clinical trials. This is a slide from Dr. Mina Cedric, who is becoming a leader in this area, or is a leader in this area. And this is a paper that I would recommend reading that describes the barriers to accrual to clinical trials and proposes solutions, including better study designs, eligibility criteria and endpoints. And it's really not easy to fix culture, but we need to be less ageist and really prioritize the needs of older patients that we see. And our structure is ageist. It really doesn't prioritize older patients, which is why this issue keeps perpetuating that we don't have good safety and efficacy data. I'll end with just two tributes. So Scoreboard is our patient advocate and caregiver board, and it's now affiliated with the Cancer and Aging Research Group and is a resource to the community. We've published our experience with Scoreboard here, and Miss Beverly Kanan leads Scoreboard. She's this lovely woman here in the purple. Two of our members recently have passed away. Mr. Robert Harrison helped me personally and helped inform a lot of our earlier work, but passed away from advanced prostate cancer. And he suffered quite a bit with symptomatic burden from advanced prostate cancer. You can see the cane here. And then Miss Margaret Settingquist is this lovely woman in the red here with a striped jacket. She was very vital and fit at 93 years old and was the co-lead with Beverly for Scoreboard, but unfortunately passed away recently from COVID just in the last few weeks. And so this Scoreboard here of patient advocates is experiencing what we experience in the clinic with our patients and what our patients experience. And we need to really do better for them. I'll end by just echoing a tribute to my mentor, Arthi, who said that historically research left out people who are older and more experienced, which doesn't make much sense. We're changing that. Older people have a lot to teach us. And thank you to my team. My team is lovely. I'm tearing up, sorry. Our team is lovely. We have a diverse and wonderful team. And I, for those that are listening, it is really powerful to have a diverse team that has multiple multiple perspectives due to background and due to discipline. And I would encourage you all to try to develop those teams or work with people within those teams, because it really advances and it elevates the research that you'll do. So thank you very much.
So thank you, Supriya, for that really fabulous presentation. And you, I think, taught everyone so much about the burden of cancer in older individuals, as well as the challenges in terms of delivering cancer care to these individuals and the toxicities that they face. So we're very grateful to all that you've done, and also for being part of our consortium. I think there are a couple of there's some questions in the chat box here, and there's a very interesting one from someone asking about preclinical research related to cancer related peripheral neuropathy, and should they be studying young adult mice or older mice, and what would be the importance of thinking about aging in preclinical models if we're looking at toxicity?
Yeah, I think this is a great question too. And I work with basic and translational scientists at the Wilmot Cancer Institute and nationally. And a lot of the recommendations from some of these panels that I discussed earlier do recommend using older mice to really get a context of what might work or what might not work. I think we have to learn from young mice, but I'm not a basic scientist, so I feel like it's maybe more expensive or more difficult to work with older mice, but it's definitely important because we're missing out on some of what the consequences of treatments and of symptoms would be if we're not using preclinical models that are as closest as possible to what we see in human beings.
So there's another question about the acceptability of geriatric assessment tools in clinical practices. I guess one question is, in the places where you did the research, are they using them? And the group that was in the control group, have they adopted them?
Yep, so that's a great question too. So the next phase is really implementation, and Cancer and Aging Research Group has an implementation core actually, and is really working with partners like ACCC and ASCO to try to implement. I will tell you, I was surprised. I mean, the oncologists could have thrown the geriatric assessment in the garbage. They didn't really have to use it, but I do think oncologists care about this. The community oncologists looked at the results. You could see from the differences in treatment that they utilize those results at the point of care. So I think it is about implementation, about workflows and helping staff learn how to do this. And we can do that through education and practice level workflows. I do hope also that there is reimbursement for geriatric assessments, sort of direct reimbursement by Medicare. And I know people have sort of argued for that. That would be helpful too.
Another question really raised the concern about potentially reducing doses. And you did show overall there was no difference in survival, but is there any concern that the kinds of dose reductions might limit benefit? And of course, your studies were done in advanced disease patients, but what about in, say, somebody getting treatment for curative lymphoma?
Yeah, so that is a concern for curative intent treatment, and I think we need more research in that area. I will say that I'm more concerned that we don't know the safety and efficacy of treatment in vulnerable older adults to begin with. So I think the dosing that is perpetuated from phase 1 to phase 2 and phase 3, and Dr. Gansett, we've talked about this at our consortium, it's just not appropriate for these older adults who are vulnerable. And so their dose reductions may be very appropriate because we've never really defined the appropriate dosing to begin with. So I'm less concerned about that for the advanced cancer setting than I am about curative intent. And I do think we need to be very careful on curative intent therapies.
There's a question about skin thermal hypersensitivity and nerve pain, even years after treatment in long-term survivors. Are there any treatments to manage these conditions? I could say that we're challenged by that.
Yeah, I don't know that. Unfortunately, these are it's still an open area of opportunity for us. So we don't have specific recommendations. There have been some guidelines by ASCO that actually summarize, and I actually think exercise is non-pharmacologic therapies have been very beneficial for patients in terms of symptomatic burden across the forum, but pharmacologic therapies can be difficult for older adults.
There's another question about opportunities to investigate the involvement of aging immune response in the treatment of older vulnerable cancer patients and how that may play out.
Yeah, so we at Wilmot are doing quite a bit of that work, trying to look at the newer therapies, immunotherapy, and looking at how the immune system responds to cancer and treatment, and how to utilize the immune system as a opportunity to treat cancer in older adults. And again, another open area. A lot of the data I show is for chemotherapy. We haven't caught up with the treatments that are out there and growing now. Immunotherapy and targeted therapies have different side effect profiles. So we really need to learn about geriatric assessment and those outcomes.
Is there data regarding the relationship of RDI and pharmacokinetics in older adults?
So now I'm not aware of it. There may be, but I just don't know the answer to that question. And I don't think RDI is used as a clinical tolerability metric very commonly in general. And what we see reported in therapeutic clinical trials is CTCAE, clinician rated CTCAE, maybe prevalence of dose reductions and dose modifications, but they don't RDI, they don't incorporate sort of a comprehensive RDI metric. It's more relevant for real world practices too, because in protocols, it's more prescriptive about what you do. So RDI is probably more applicable as a tolerability metric in studies like mine rather than a therapeutic study.
Just my own thoughts about that. Have you even looked at your clinical practice at Rochester to kind of look at clinically treated patients where you're geriatrically sensitive to these things?
Yeah, we should. We haven't yet, but this is a great idea.
The RDI would be something that you could look at and see if it
absolutely
made a difference in outcomes. Mm-hmm. Do you see the cancer-based CGA as an assessment that supportive care or rehabilitation practitioners might adopt to track outcomes in older adults?
Oh, yeah. So we actually, Dr. Ramsdale, Erica Ramsdale is an EPIC builder and geriatric oncologist at the University of Rochester Wilmot Cancer Institute. She's built in the GA into EPIC, and we hope to implement a procedure where we're actually doing key metrics over time, which we did in GAP and COACH, where we measured ADLs and physical performance and cognition over time. So I do think that that's, again, the next step.
And a question here is, can you give us a simple rule for dose escalation decision for older patients? So say if you do start out at that lower dose because you've done.
Yeah, so there is a study that I like to use when clinicians ask me this question. It's called Focus 2. It was by Dr. Seymour, done a few years ago for patients with advanced colorectal cancer. What they found was when they started off with a dose reduction, a therapeutic dose reduction, and they allowed the oncologist to increase the dosing if patients tolerated treatment. What they found was only 1/3 of these older adults were able to increase dosing. And it was really left up to the oncologist and shared decision-making model with the patient. I saw another question about, a priori dose reductions. And I think there are trials to show, especially in the GI world with both colorectal cancer and esophageal cancer, that doing a 20 to 25% dose reduction up front in the advanced care setting may be beneficial.
And I think this will be our last question. Would you have expected to have had different results in your study if you had recruited all comers, i.e. not only patients with greater than one impairment? I mean, obviously that's a study design issue to be able to measure.
Yeah, we wanted to look at the impact of the geriatric assessment on patients for which palliative treatment may not be the right thing to do because of the geriatric assessment problems. And because there's so much uncertainty. We have a trial that we're doing next in survivors. So patients coming off of chemotherapy, we built in healthy living as a part of the intervention. And so we are including patients who don't have geriatric assessment domain impairments in there because we can do something with them. We're going to do education and exercise and those kinds of things. So that is our next step, but we didn't do that for this study.
Dr. Gans, before we finish, Diane had a question.
Oh, I think we're out of time.
Okay.
I think we probably need to wrap up. So I will ask it when I.
Diane and I talk regularly. So
yeah.
Okay. Yep.
So thank you. So that concludes today's session, and I just want to thank Dr. Gans very much for moderating today's session, and Dr. Mohile for the wonderful, wonderful presentation. Thank you so much. And as a reminder, the next Moonshot Series lecture is on March 25th. Dr. Christina Curtis from Stanford University will be discussing the Blue Ribbon Panel recommendation focused on generation of a human tumor atlas. So thank you very much for all of you joining us today, and have a good rest of the afternoon.
Thank you very
Bye.
much.